I think we are all experienced this. Next question is, do you have experience with CAR T cells, bispecifics, or other novel agents in your own practice? So we don't do CAR T where I am. I refer to Matt Lunning. He's exactly 2 hours from me, but we do all bispecifics. We have several trials. And so we have a complete outpatient bispecific program. Patients do amazing, and we have for the last 3 years, starting with the first trials that were being done. And so, yeah, I have a ton of experience with bispecifics in standard of care and in clinical trials. And so that's where most of my experience lies. And obviously in the other novel agents, I think we're all probably pretty familiar. But we don't do CAR T in-house just because for us, because of our relationship with Nebraska, it's just made more sense to refer because the back and forth is so smooth. There's no issues. Patients love the relationship that we all have with each other. So for us, it hasn't made a lot of sense to bring CAR T in-house.
So, Tara, I'm going to push you further on that one, right? Right now it's working, but that is because most of the patients you're referring have relapse disease. So do you foresee that as CAR T therapy becomes first line, or potentially becomes first line treatment in diffuse large B-cell lymphoma, and maybe even in other malignancies like multiple myeloma, how do you really foresee this relationship remaining the way it is, or does it become necessary that patients are treated closer to their home?
It depends on the end, right? It's the same conversation that I have with community oncology groups who don't want to do bispecifics. I asked them the same question. I said, well, wait a minute, bispecifics are here to stay. I'm like, they're being approved not only in malignant hematology, but small cell and, in the future, lung and breast, that if you don't learn how to do bispecifics, you're going to miss the trains leaving without you, right? So you're asking me the same question about CAR T, which I've thought about, and we're fully able to do CAR T. So I think in the future that might be something that does change where we decide to do it in-house. Right now, it's been an additional thing we've made the decision not to bring on. We have a full phase 1 program. Like I said, we do bispecific. So can our center do CAR T? Yeah, absolutely. That's not really the issue. It's just a matter of geographically, our situation has worked out so well, but that's not the case with every institution across the country, right? Not all large community groups have that relationship with an academic center like we do with Nebraska, right? So my situation's a little bit unique, but you're right. It is something that I've thought about, and in terms of logistics, in terms of additional ancillary staff, in terms of hospital relationships, which hospital to use. So yeah, no, it's definitely been something that I've thought about a lot, and probably a lot more just because of the rate in which things are changing. So no, I think it's something everybody needs to think about. Do I think every single center is able to do CAR T? No, just like I don't think every single center should do a bispecific. I think there's definitely, things that go into being able to have a successful and safe program.
So Tara, along those lines,
Yes.
I'm going to ask a quick question. I think that sounds great, and I don't think anybody needs to do anything beyond what they need to do. So my question is, do you ever have a situation, and I say this more for the recording than I say for our conversation, but do you have a situation where you ever would have a patient eligible for CAR T and would go to bispecific first?
I have had that. I've had that scenario. And usually it's patient driven. I discuss with them. I always say, if you're a CAR T candidate now, go for CAR T. The bispecific's not going anywhere. But there are patients that just won't do it. And, Matt and I joke around a lot because we live in the Midwest with farmers, right? And there are some of my farmers, they are not getting off that tractor and they are not going for CAR T. I mean, they will come in once a week to be loaded for their step-up dosing for a bispecific, but they're not traveling. They're not doing it. They're not doing it. And, we hear all sorts of different reasons for that. Not just that. I just make fun of the Midwest sometimes because it's definitely an interesting place. But But yeah, I definitely have people that and not just CAR T versus bispecific, it's a CAR T bispecific novel agent, right? Because there's so many, we're in the state, or sorry, we're in the day and age now where we can have, I can lay different things out. Like here's CAR T, here's bispecific, here's tafelen, here's whatever it is. Here's clinical trial. But if it was just merely down to bispecific or CAR T, if they're a CAR T candidate now, I always try to encourage them to do the CAR T.
And if I was to follow up on that a little bit, even within the bispecifics. So, for example, at our place, we decided that we would do all of our bispecifics at our main hub, not in our satellite clinics. And even the patients in the satellite clinics, they don't want to come to the main hub to get their bispecifics. They want to be at the smaller clinic. So it's not just even a question of academia versus non-academia, but it becomes a rural versus urban divide. And even within that, it's ultimately patients want to get the care closer to home. And hopefully, as more people get trained, that will no longer be an issue. And maybe the technology will be so advanced that patients could just simply come in and be treated locally. But these are some of the challenges. So Suzanne, what is your experience? What has been, you have both. So you may have the unique experience of being able to offer both, but I'm sure there are situations where you choose one for each particular patient.
Yeah.
Not because of inavailability.
Yeah, no, I agree completely with Tara. I mean, I do think that because there is some curative potential that we are aware of with CAR T, that should be offered in a eligible patient. I agree wholeheartedly that patient selection is, patient choice is very different. And patients choose all sorts of things. But I would also say, kind of going back to the unmet need question, there are patients who fail CAR T and then go on to one thing or another. So right now I have a patient who failed CAR T at MD Anderson because he left the area. Could have done well at home, but still, can't argue with MD Anderson. And came back and now is on EPCOR and is doing fantastic. He's like a year and a half into EPCOR. Now I have a patient who failed CAR T and then failed EPCOR. And then I put on R squared because this is a guy who obviously by the case of the sequence of what I'm telling you, he failed everything so fast. And he had, what I would call a durable response at this point with R squared. He also has secondary CNS, but has been on R squared for a period of time and is now failing. So, that's somebody who, maybe I'll think about an allo CAR T trial, but there's not much left for someone like that, who's really kind of been through all of it. So I like what Tara said earlier, that maybe we won't have third line in the future, but I just feel like we're always going to have some of those people that just don't behave, and exhaust every option we can think of. But Josh, what do you think?
I would even argue before Josh answers that Tara is a classic oncologist because her glasses are not only rose colored, but they're super rose colored. That's why she believes that they'll.
Like what? Let me dream, damn it.
All right, Josh.
I think we can agree on most points. Number one, that Tara's glasses are super cute, regardless of the precise color. I couldn't distinguish a mauve from a periwinkle from a rose. I mean, they're all real close, but they're super cute. That's a fact. That's not an opinion. And I think also, I would also say that although we have CAR T in-house and don't refer patients out for that, if I have a patient with like some kind of hairstyle emergency, I'll refer to Matthew Lunning in Nebraska because he's the only one we trust for, complex, mutton chops versus some kind of new goat tea something or whatever. So, we refer to only for that. We refer to Matt Lunning as well, not for CAR T. But yeah, collaboration there has been also very good. I agree with everything that's been said. I forgot what the actual question was.
What has been
No.
your experience with CAR T and, and
Yeah.
bispecifics, and if you have them at your center?
Sure.
See,
So we're
Tara, see
very
what your
lucky.
glasses are doing to people, getting Josh all confused.
Getting me, yeah, all in a huff, really. I mean, before, the huff was over here, and now I'm in a huff now. I'm right in it. So it's a great question. We're very lucky to have bispecifics and CAR T at our center, and it is not one size fits all in terms of which one has to go first. Absolutely, in this particular setting of second line rapid relapse DLBCL, Zuma 7 transformed trials, those patients should get access to CAR T. But let's be fair, a lot of those patients are getting debulking therapy before they ever get the CAR T. So what is the right debulking for them? We get some bispecifics into that regimen frequently. StarGlow trial has second line patients in it and an overall survival benefit. So, why couldn't patients get some GemOx plus a bispecific? It probably could be GlowFit or EPCOR in combination. I mean, that is an awesomely effective regimen, 60% CR rates in both that StarGlow and also in the EPCOR plus GemOx trials. So yeah, that could be debulking in that sense. Like Suzanne was asking about, they did kind of get their bispecific before their CAR T, even though we're kind of teeing that patient up for a second line CAR T. It was sort of third
But
line.
you're bringing up a very important point, right? Which is, what do you do with a patient? Let's say a patient who had relapse disease, they quote unquote get debulking therapy, and they get a very deep, meaningful response. And the patient is asking you, doctor, do I really need this CAR T? And of course, we don't have the answer to that question because the studies haven't been done yet. But what is the practical answer to that question?
I was really told there would be no tough questions at the meeting today, but we have a lot of those, actually. We have a good number of those, not a lot. We have a significant number, and that's where we would love to have an MRD assay that really kind of helped us to stratify those patients. And a lot of times we got the insurance auth for the CAR T before that deep remission. So some of them have a CAR T already ready to go. And, it should be real simple. So we say to them, this is a personalized decision. If it ain't broke, it is hard to fix it. They're getting a great response with, let's say chemo plus bispecific or whatever it is. And they're tolerating it well. It is hard to change course when things are going great. So we give them a choice. But at the very least, then, we're on sort of a trigger hair warning. If their CAR T product's already available, we could just watch them very closely on the bispecific and, have a hair trigger to give them CAR T. I have had patients who have just said, you know what? Keep the CAR T in the freezer. I'm going to keep going with chemo plus bispecific as I've been getting. And we have some of those patients in remission for 2 and 3 years now because they went on trials. And hard to tell them they need more therapy when they've been in CR for years. So we tee them up for CAR T. Not everyone that gets teed up actually, hits the range.
So I'm going to add real quick. My patient who came back from MD Anderson really actually had like a PR to his CAR T, and then we jumped right in as soon as we knew it was only a PR. Jumped right in with EPCOR. So I think that recognizing those patients and not waiting and moving into the bispecific is going to make a big difference too.
Suzanne, was that the first one that you mentioned that had the great response to the EPCOR, or the second one where they still ended up with progression?
Yeah, no, that's the one who's still on EPCOR. So he went to MD Anderson for his CAR T and really had a big bulk of disease. So you could argue that maybe he should have been debulked more before he got to CAR T, had a partial response, and then just came home and we just started EPCOR. And now he's been doing great. So yeah.
It is tricky because that guy had flu-cy less than 3 months ago, it sounds like. So his T cell counts are suboptimal. So we're hoping for the EPCOR to do its job, but that is tricky because in the trials, there were no, 3-month patients. Well, 3 months was around the cutoff. You weren't allowed onto an EPCOR trial if you had, CAR T 60 days ago or 30 days ago. But they were like 90, 100-day cutoffs when you were allowed back on EPCOR. So it sounds like that guy's right around the 90, 100-day maybe. Yeah.
Well, he wasn't on a trial.
Yeah, no, but
Yeah.
the great results we have of EPCOR post-CAR T come from those cohorts.
Right.
They only were, so if you say, I want to get a, 39% CR rate post-CAR T or a 34% CR rate, those come from the trials where they waited 3 months. And if you put someone on 2 days after flu-cy, hard to, be hopeful we're going to get the same great result that we got in those trials, yeah.
And the other, it's hard to know when to, so we're imaging 30 and 60 days post CAR T. And so, it's fast.